Okay. Well, good afternoon, everyone. My name's Satyen, and it's an absolute pleasure to be here today to talk to you about attempting to predict sepsis mortality on admission to ICU. Essentially, we're going to cover what exists and is it any good. Now, first of all, kind of like the Australian economy and unlike myself, we're going to be a bit innovative and agile and start off with a few fast facts. So, this is my beautiful workplace. I'm not really working yet, still a student, but Cairns Hospital, it's absolutely stunning, lovely, tropical, 26 degrees today, for those that were curious, and that's why I'm so rugged up, because I'm finding it a bit of a struggle here with the Melbourne cold weather. But look, it's lovely to be in Melbourne. A couple more sort of fast facts, fun facts. Best restaurant I've experienced so far, Chin Chin around the corner. Best bar, Embla on Russell Street. Go there tonight, it's fantastic. Best coffee, I've learnt not to have an opinion there. We're in a room full of Victorians. But look, a couple more, as I was introduced as, 60-year JCU medical student. Almost feel like a bit of an imposter in a sense, bit fraudulent. Some amazing names in this room over here. As I said, it's a real privilege to be here. And a first-time conference presenter, so this is kind of new and unique and a bit fun. Probably the most shocking fact of all, we have no good way to predict sepsis mortality on admission to ICU, and we'll explain that in a bit. But let's get into the meat of things, as we say in Far North Queensland. Let's crack on with it. Sepsis 3, as we sort of already discussed in the morning sessions today, essentially defined as life-threatening organ dysfunction, second to a dysregulated host response to infection or suspected infection. Usually includes a SOFA score increase of greater than 2 on admission. Fast facts here, there's approximately 15,700 cases of sepsis in Australian hospitals every year, causing greater than 3,000 deaths. Cost per episode, $39,300 Australian dollars. That's quite significant. It's a lot of money. We think about the humanitarian and the healthcare aspects of sepsis, but there's also obviously, apart from a million and other reasons, there's a big economical burden as well. Approximately 21% of all Australian ICU presentations are due to sepsis, and approximately 90% of all patients admitted to Australian ICUs from sepsis will die. Put it simply, 1 in 5 patients you'll see will have sepsis, 1 in 5 of those will pass away, unfortunately. Professor Ronaldo's probably not in this room, but that's citation number 1,201 for him now. So my aim was to investigate mortality prediction models that are used for septic adults on ICU admission. And really, we just want to know, are we able to predict this? Why is this important? Well, a couple of reasons here. Early recognition can lead, of the acutely deteriorating or dying patient can lead to improved risk stratification. It can help guide clinicians' approaches to treatment and assist in prognostic and end-of-life discussion. As we heard in yesterday's afternoon session, end-of-life discussions and prognosis is quite important. For research purposes, it helps with unit assessment, standardisation with SMRs and so on and so forth. But let's put this all in the context of an example. Imagine this. You're an intensive care clinician. You probably don't have to actually imagine that. I do, but you don't. You're probably all working there anyway. Look, you're alone. It's late at night, and you've been asked to admit a patient from the ED. Now, discussion with the family ensues, and you're unsure about what the prognosis might be, and potentially how to treat. Now, a good mortality prediction model in this example could help in a number of ways. Let's imagine that you had a patient with a 5% risk of mortality versus a 50% versus a 95%. A patient with a 5% risk of mortality, you might perhaps treat a little bit less aggressive, a little bit less invasive. You might not jump straight to arterial lines and jump straight to central venous lines and so on and so forth. A 50% risk of dying patient, you might treat a bit more aggressively, a bit more invasively. You might start, we're talking about invasive lines and procedures. But a patient with a 95% chance of dying, you're probably going to start to think about end-of-life discussions and palliative measures. So, what do we do? Well, we had a look at a couple of databases. In the literature, we looked at the Scopus, PubMed and Cochrane databases, probably being 3 of the largest and best. And we only included mortality prediction models that we used within 24 hours of ICU admission. Defining ICU admission time was a bit of a tough one. To define it as within 4 hours, at exact point of admission, within 72 hours. We picked 24 because it's pretty consistent. Well, it's somewhat consistent across most of the literature we've read. Patients have to have a primary diagnosis. This is quite important of sepsis, but we're talking papers here over the last 20 or 30 years. So we included sepsis, severe sepsis, septic shock, SIRS criteria, all the various iterations of the sepsis syndrome or sphere that have existed previously. And we included only patients that were greater than 18 years of age at time of admission to ICU. Now, we excluded mostly case studies, studies with only descriptive statistics, or those that had no prediction model. So, what was our results? So we assessed 1,572 studies, essentially ended up with 20 full-text studies of 16,415 patients. Now, the main reasons for exclusion throughout this whole screening process was because most of the patients were aged less than 18, and we thought let's just separate paediatric from adult studies. The models that were used for these patients were not ICU specific. So there's a couple of models that are used in the ED that are used on the wards. We talk about QSOFA, so on and so forth. That's probably not applicable in this setting. Or models that weren't sepsis specific or used for sepsis specific patient cohorts. So we know that things like the Apache models are used for all types of patients. It doesn't distinguish between sepsis, oncological patients, surgical patients. And models that weren't used within 24 hours of admission. So there were some models that were used, up to 72 hours, up to 48 hours. We thought, let's keep it on admission 24 hours. We also assessed studies for methodological risk and risk of bias by looking at whether they included missing data or whether they defined the variables, so on and so forth. So, what exists is a big question. Essentially, let's break it up into three big key groups. There are the generalized mortality prediction scores, there's the organ dysfunction scores, and then there's sepsis-specific scores. So, generalized mortality prediction scores. These include the Apaches, the SAPs, the mortality prediction models, which most of you might have heard of, if not know quite intimately well. The key things here is that they're not sepsis-specific. They were not ever intended to be used for individual patients and prognosticate individual patients. It's usually used for cohort factors, and not sepsis-specific. Organ dysfunction scores. Great for defining organ dysfunction and quantifying severity of organ dysfunction, not great for sepsis, not specific to sepsis, doesn't differentiate between a septic patient, an oncological patient, a surgical patient. And then there's the sepsis-specific models. And when you think about it, when we're trying to predict sepsis mortality, we really should be using sepsis-specific models. I think that just kind of makes a bit of sense. And the main ones here that they used are the PIRO model, which I'll touch on in a bit, and the simplified mortality score. Now, the PIRO model was quite interesting. It's a well-validated model that tries to stage sepsis in the same way that we'd stage cancer. We stage cancer with TNM classification. We can apparently stage sepsis now with PIRO classification. Let's break it down further. Look at the variables. So predisposition variables might include age, gender. Insult or infection variables might include, is this person septic because of a bacteria, a virus? Was the bacteria gram-positive, gram-negative? What was the actual bug? Response is just usually acute physiology. What was their heart rate, rest rate, lactate doing? Organ dysfunction looks at things like, was there elements of acute kidney injury, transaminitis, a troponin leak, so on and so forth. Simplified mortality score was a paper written in 2009 by a French team, which looked at age plus SAPS2 plus coagulation markers for sepsis-specific groups of patients. And I think their theory working on that was that coagulopathy tends to be a pretty good predictor of mortality and sepsis. But let's see if they're actually any good. So we took those three broad groups of models that exist out there, and we assessed them all for discrimination, as measured by area under the curve, and calibration, as measured by the Hosmer-Lemershow Goodnessoffit test. All p-values here are less than 0.05 and significant. So the generalized mortality scores, bit of a busy slide, let's break it down slowly. If we think of a good prediction model, it should predict both high in terms of its validation. Validation is a measure of discrimination. Discrimination essentially says how well can the model predict if the patient is going to die. How accurate is the model predicting death, really, right? So that's what we see in the internal validation and external validation columns. Now we take flipping a coin. You flip a coin, I think the example was given before. You got a 50-50 chance of predicting right, whether it was heads or tails. Calibration is essentially how well does what we have predicted actually match with what actually happened. So if we predicted that patient was going to die, did they actually die over the whole cohort? And a p-value of less than 0.05 is significant in that model was calibrated really well. And probably the key here is knowing that discrimination and calibration are both equally as important when trying to create a good predictive model. So they both have to be read in context. So let's go through results really, really quickly. As you can see, there's actually not that many studies out there that look at these things. And if you look at the validation column, i.e. how accurate the model was, these range greatly. The Apache score from less than 0.5, i.e. worse than flipping a coin, all the way up to one study where it had 0.93 or 93% predictive accuracy, which is, in an isolated result, fantastic. But if you look at that variability, it probably doesn't fill you with a great deal of hope and trust in that model. Calibration, however, in one study out of 13 was good. I guess what we're trying to say here is that none of these generalized mortality prediction scores have great external validation, consistent external validation, and are consistently well calibrated. As you can see, the rest of the results are there as well, essentially saying a similar thing. Let's jump to the organ dysfunction scores. LODS, MODS, and SOFA. Once again, look at the number of studies. There's not that many that are well studied. The SOFA was probably the best studied score, and it's probably the one we use most commonly, or we've heard of most commonly. External validation, once again, not great. In the one study with the LODS model, 0.83, 83% predictive accuracy is actually not too bad. We look at the SOFA score, like Apache, like SAPS, far too much variability in its external validation. I mean, one cohort found that it found an accuracy rate of 54%, one had 85%, just extremely variable. And once again, the calibrations were a bit not fantastic as well. But the LODS was once again okay. I guess this hints that, you know, there's in a black hole here where there's nothing that's excellently validated and well calibrated. There are a couple of sort of little sparks of light that shine through, and that LODS and some of the SOFA scores also hint at the fact that maybe there is a bit of organ dysfunction we have to keep in mind when we're trying to look at a dying septic patient. Let's look at the sepsis-specific models, and there are a lot of these, but we really try to reduce the list of potentially 20 up to the top most important ones. So as you can see, there's a lot of the PIRO models that are over there. Probably the best performing internally validated models, and internally validated models are the ones that are made by the authors, not made by someone else. Pretty good scores. 84% for the Granger et al. Paper that created their PIRO model. The simplified mortality score, which I mentioned before, was the best performing model that we found with a 93%. And there's an AIM score which was made in one paper in India with 100 patients with 84%. So probably better overall than the other models that are presented in the other categories, but still not fantastic. We're talking about that these are isolated great results for one paper, only internally validated, never externally validated. No one else has been able to reproduce these results. Calibration, as you can see here, less than 0.05 is good. Neither the Granger or the SMS were fantastic. They weren't statistically fantastic for calibration, i.e., it was really accurate in predicting who might die, but some people that predicted might die didn't actually die. So a bit of miscommunication there, because isolated you see these results and think, oh, that's actually not bad. If I could predict 93% of the time who's going to die from sepsis, that's pretty good. Calibration doesn't quite fit. So in discussion, sort of a couple of findings here. The calibration discrimination trade-off. I'll let you reflect on what you think for the moment. Whether these are any good, whether the calibration and discrimination are both consistently good for any of those models we've just discussed. Quite interestingly, I think, is that the role of sepsis-specific biomarkers such as procalcitonin, lactates, these are single biomarkers that are novel, highly prospective, that we know correlates strongly with sepsis mortality. Adding these biomarkers to already known existing models actually increase the existing model's performance. I think that's quite interesting. So you take, let's take the Apache 2, not sepsis-specific, but if you add a couple of sepsis-specific biomarkers to that, it improves the model, and it did that across all three studies that investigated that. Also, the best paper, the simplified mortality score, took that concept of taking a SAPS2, and they found that the coagulopathies in sepsis seem to predict quite well mortality. So let's add that to SAPS2, the acute physiology sort of scores, and between a bit of organ dysfunction, a bit of acute physiology, you've got a pretty good score. But really being sepsis-specific and holistic seems to be the key. So the sepsis-specific models overall outperformed other models. Quickly, strengths and weaknesses. Well, this is the only and best up-to-date literature review of this topic that's there at the moment. A couple of weaknesses. The definitions of sepsis changed across all the papers. The way that we worked out the mortality endpoints, i.e. 7 days, 28 days, 90 days, so on and so forth, varied across papers, and there was different definitions of admission. Some of the models were used within 4 hours of admission, some within 24, some within 6. But the take-home points, what I think is important to take home today is that in our opinion, and from what we've seen with the stats, the validation, calibration, statistics, there is no model that is consistently accurate, validated, and well-calibrated to predict sepsis mortality on admission to ICU. A good sepsis mortality prediction model should, apart from being easy to use, cheap to use, clinically very available, it should be sepsis specific. I think that just makes logical sense, and the limited evidence backs that up. Probably should use a holistic approach. I think this PIRO staging of sepsis concept is quite interesting. It is holistic. It can add any highly predictive marker to the model and increase the model strength overall. And importantly, it combines pathophysiology with a bit of organ dysfunction, with a bit of acute physiology. And I think really for sepsis, that's what it is. It's such a wide and varied syndrome. We have to take a holistic approach. Sepsis is not just organ dysfunction. It's not just acute physiology. It encompasses a spectrum of different predictive variables that can impact on it. And an accurate model would help clinicians and researchers risk stratify, prognosticate, guide management. At the end of the day, this is a safety and quality conference. I think that this is really important for the delivery of the safest and best quality care for our patients, and this model is yet to be created. A little plug for future research. This is the first part of my honours project. The second part, which we're just in the process of statistically analysing now, is to try and create one of those models and also to validate some of the existing models as well. So watch this space. And I know, to finish off, that there's been a lot of Donald Trump memes being thrown around at this conference. I hate myself for doing it, but I think it's, anyway, it's Donald Trump. It's always a bit of a laugh. Look, thanks to everyone for having me, and to those involved in the project, and to all the organisers. Cheers. Appreciate it.